Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Hello, friends. Welcome to the Senior Rehab Podcast. Thank you for your download. Today's guest is Lora Giangregorio. She is an associate professor, a PhD at the University of Waterloo, and her aim is to reduce the burden of osteoporotic fractures. She is doing some amazing work, creating some very useful content to help patients better take care of themselves and reduce the risk of fractures, and also educating people like me and you, the rehab clinician that works with older adults. She is a Canadian physio, which continues my crush on those Canadian physios out there. Shout out to you all listening. But she's a great person to talk to, super knowledgeable and really knows her stuff. And so I gained a lot from this conversation, just learning the ins and outs of what I should be doing with my patients that have or have not been diagnosed with osteoporosis. So you'll find this useful. Let's get into it with Lora Giangregorio. Lora Giangregorio, welcome to the Senior Rehab Podcast. I appreciate your time.
I really appreciate you having me on the podcast.
All right. So I wanted to have you on just because you are quite the expert in terms of bone health and exercise and how, we should work with people that have been given that lovely osteoporosis diagnosis. But before we kind of jump into that topic, I'd love to hear about your career, kind of the quick and dirty of your path up to this point.
Well, I started my undergraduate degree in kinesiology at the University of Waterloo, and it was funny actually because I really wanted to be a French teacher in high school, and all of a sudden and I decided that I think in one of my last years in high school I completely changed course, and it was on the advice of my cross country coach actually. Oh. And he, I just said, I'm really interested in the body. And he's like, why don't you try kinesiology? And I didn't even know what it was. So, I started in kinesiology and thought I wanted to be a physical therapist. And I realized quite quickly that it wasn't the path for me. And it's a great path, but it wasn't the path for me. I volunteered in a few physio clinics, and I volunteered as a student athletic therapist and as an ergonomist. I tried a lot of different things, and I didn't quite find the right fit. And then my fourth year, I did an honors thesis project where I got to, go to the library and do research and read and, come up with ideas and try to pull them all together. And I know this sounds really geeky, but that was one of my favorite experiences in university. It's just hunkering down in the library and reading a bunch of stuff. And,
wow.
I know. It's anyway, so I really enjoyed it. And so my supervisor suggested I go on to graduate school. So I really enjoyed cardiac rehab. So I called, an expert in cardiac rehab, a Canadian expert, and asked him if I could be his master's student. And he said, yes, that would be great. So I came to work with him. This is going to be a really long answer. I'm so sorry.
No, I like it. I love hearing these stories.
And so I went to work with him, and just at that time he'd gotten a grant to do some work in spinal cord rehab. And so he said, well, we have this project, if you want to work on it. And I ended up staying and doing my PhD looking at bone health in people with spinal cord injury, which is completely different than what I sort of had signed up for. But it was a lot of fun. And in that time, I met some other mentors who taught me a lot about geriatrics and osteoporosis. And I was able to sort of bridge that gaps in my knowledge. So I had some kinesiology background, but then I was also able to work with physicians, rheumatologists and geriatricians and biostatisticians to learn a little bit more about their fields and how I could apply it to kinesiology. And then I ended up doing a postdoc in the lab of a biomedical engineer who was interested in developing electrical stimulation devices for people with spinal cord injury, and we did a trial looking at effects on bone and muscle health. And it's kind of where I started to think about what's my niche going to be. And it was really just bringing together sort of the kinesiology and the geriatrics and clinical epidemiology to try to address big problems related to people, to osteoporosis. But I wanted to focus on people at higher risk. So not the prevention, but the treatment. And so that's where I moved forward, and I've done lots of different things. And Too Fit to Fracture was a really exciting initiative that I got to be part of. So.
Yeah. So quite the journey, and quite the plethora of topics that you've studied. I'm curious to know. Let's go back to the bone density in the people that have suffered from a spinal cord injury. Was that just kind of excuse me, an opportunity that you're like, okay, I'll do this, or was it like, yes, this is what I want to do. I want to work with this study, with this population. What was your mindset going into that phase?
A lot of when I take on something, it's because either I don't know a lot about it, or I feel like it's an intriguing topic because there's not a lot known, or there's some risks and challenges. So that topic was really interesting to me because, bone changes really slowly. And so it was really interesting to me to figure out, okay, well, how can we actually, target bone with exercise to try to make a change? And then the idea of people with spinal cord injury, I didn't, but prior to being involved in that work, I didn't quite realize the secondary complications that can occur following a spinal cord injury. So when you hear about spinal cord injury, you think, wow, a person is paralyzed and they can't lose their arms or they can't use their legs. And, you think about that as the major impairment. And what you realize when you start to do research and reading is that, yes, that is an impairment, but there are many other secondary complications. And often those become more important impairments in their life because they then lead to things like pressure sores or infections or fractures. Those they can be quite problematic. And it was an opportunity for me to learn and grow my knowledge, but also to appreciate when we're designing interventions, we need to think about addressing real world problems. So, coming into it as a grad student, you think, oh, I want to look at the effect of this on this, and is there a change? And it's all about, does it, is there a significant difference? And when you actually start to work with people, you realize I need to ask questions that are important to people, or questions that are going to move the way we treat people forward. And yes, it's important to design it properly so that you get a important outcome, whether it's a statistically significant difference or not. And sometimes the not is a really important thing, like knowing that an intervention doesn't work and designing a study to prove that is equally important. A lot of people focus on sort of, what are the things that make a change. And it's also important to know what doesn't work and to design studies properly so you can adequately answer those questions. So the first thing I guess I would say to your answer is that was my first realization that we needed to think about patient-centered research questions, or knowledge user-centered research questions that were actually answering important questions. And the second is understanding that it's more important to design the study to answer the question properly.
That's a good point. Do you feel like that is rare in rehab research, in terms of what you just said, in terms of letting the questions and the problems that the patients are facing form what we research?
I don't know that I would say that. I think many people who are doing rehab research start as clinicians. And so they're often driven by the questions that are important to them as clinicians. So I wouldn't say necessarily that's true. But I do think it's important to go back to the clinical setting. So what happens, I think, often is you're a clinician and you are driven to research because you want to be able to make change at a different level or in a different setting. But then sometimes you get wrapped up in the research, and it's important to go back. So, I often go back to the clinicians or go back to the patients, or if it's in a community setting to older adults or whomever it is I'm interested in studying, and go back and consult them about what I'm doing and get their input. Because if you stay in your lab, sometimes you miss out on some of the important cues or outcomes. So for example, I'll give you a good example. We were doing a study where we were doing the Too Fit to Fracture initiative, and we wanted to decide what outcomes we were going to look at. So does exercise have an effect on bone mineral density, the bone mineral density being the outcome, or fractures? And so when we talked to the scientists, they thought, the important outcomes are bone mineral density, falls, and fractures, right? Mm-hmm. And then I did a focus group with a few people who had osteoporosis, and particularly people who had higher risk, like they'd had fractures before, and talked to them about the outcomes. And they said, well, the fracture is important, but at the end of the day, what's really important is whether the fracture prevents me from, doing my groceries or cleaning the house or being able to, get out and socialize. And so if I'm in pain, I can't do those things. So the things that are important to me are my activities of daily living and pain and quality of life. So it caused me to say, okay, well, when we do our review of the literature and when we develop our guidelines, we have to consider those outcomes in addition to the ones that the researchers think are important.
That's a good point. That echoes what a previous guest on the show talked about, Cole Galloway. He's a PT at the University of Delaware, and he has an initiative called Go Baby Go. And he, it's amazing. I definitely check it out, but he basically is thinking of mobility in a different light, but it's very driven from the community and the people that he works with. So his lab is a real world, not necessarily in some nice shiny building, but that what you're saying definitely echoes what he said as well. I'm curious. So for you, why the interest in geriatrics and osteoporosis personally? What about that topic makes you interested in it?
I think because I feel like there's still very important questions to answer. So I find it, fascinating that, bone changes so slowly, and also that how our bones are adapt changes over time. So, when we're younger, you can actually change the shape and strength of your bones with different interventions. And when you're older, it seems like your bones become less responsive. And so, for example, there haven't been a lot of studies in people with osteoporosis that have shown that exercise can actually increase bone mineral density.
Really?
So they do. A lot of the studies often exclude people with osteoporosis, or they have some people who have osteoporosis and some people who don't, so they mix them up. So to be able to conclude that people with osteoporosis, exercise can increase bone density, you actually have to do a study in people with osteoporosis and not in, a heterogeneous group of postmenopausal women or men. And so that's a knowledge gap. And so one of the reasons they're often excluded is because people are worried about the risks of exercise in that population.
Yeah.
And the second is because they're often on medication to prevent bone loss. So you can't include them in the study because you don't know if any changes are due to the medication or due to the exercise. And often the medications themselves are medications that prevent bone turnover. So they slow down bone breakdown, but they also slow down bone formation. So if you're trying to increase bone density with an exercise intervention and someone's on a medication that slows down bone formation, it probably won't work, right? Or you may not see the effect that you can attribute solely to exercise.
Wow.
Yeah. So
you're tackling that topic head on right now. What are some findings, if you have any yet, or are willing to share?
Well, we did the Too Fit to Fracture initiative, and again, that for me doing that was because I couldn't find guidelines that were really evidence-based that had tackled the questions that were important to people with osteoporosis. So there's lots of recommendations around, do this to prevent osteoporosis, but there wasn't a good guideline to provide advice for people who had osteoporosis, and particularly those who have spine fractures, the really high risk folks. Yeah. And the other thing was that the recommendations were often specific to exercise and not physical activity, like physical activity of leisure or daily living. So when I would go out and I would ask people with osteoporosis, so I'd go out and do a talk on exercise, and they'd say, okay, well, is it safe for me to do yoga, or is it, I want to get rid of my belly, can I do ab exercises because my doctor told me I can't bend, someone might ask, can I golf, or how do I, lift my grandson safely, or can I even do that? And so I realized that we didn't really have a lot of guidance around those questions. So we did the stepwise process for the different Too Fit to Fracture projects, because there's a few of them, to try to address, what is the effect of exercise based on research, and then how do we answer these patient questions? Because there aren't studies that randomize people to yoga and no yoga and wait for them to fracture. So we can't really use research to answer those questions. But we can use, our knowledge of biomechanics and our understanding of other research to try to make inferences about it. And so what we did is we just brought together experts to say, well, how would you answer that question? And we tried to look for commonalities. Yeah. So we were able to then come up with guidelines. So that was sort of the first step. And then the next step was to say, okay, now how do we actually get people to use this information?
That's the tough part, isn't it?
Yeah. And so we went out and consulted, older adults and physicians and physiotherapists and community exercise instructors around, what are the barriers to implementing this information? And we've now sort of collected all that information and used that to develop interventions. So things that we can use to share the message. And so we developed a video series for people with osteoporosis for them to understand how they might integrate an exercise program and what exercises are safe or not safe, but what exercises they might consider doing, and actually demonstrating those exercises so they could do them at home. We developed an exercise booklet. We did some media stuff, a bunch of different things, all addressing different barriers. So Bone Fit is one of those things. Bone Fit is a workshop. There's actually 2 workshops, Bone Fit Basic and Bone Fit Advanced. So on day 1, both the Bone Fit Basic and Advanced people are together. So people who are physiotherapists and kinesiologists and healthcare providers would take the advanced course. And that's because you have to have a somewhat a more in-depth knowledge of anatomy and assessment to take the advanced course. And then the basic courses for exercise instructors, personal trainers, yoga instructors, anyone who wants to learn the basics of, adapting exercise for people with osteoporosis. And so on day 1, they're together and they learn about osteoporosis and exercise and recommendations and how they might use, practical strategies for adapting exercise for people with osteoporosis. And on day 2, there's more of a focus, is just the advanced folks, and it's more a focus on assessment and also on therapeutic exercise and rehab. So this is where you might say, okay, well, what are you going to do in your clinic with someone who has vertebral fractures to teach them how to move safely and that sort of thing. So that is an example of how we try to get it into practice, because we offer the workshop to community exercise instructors and physios and kin so that we can actually then share the guidelines through this workshop.
Okay. I want to jump back to, there's 2 topics I would love to dig into. One is just kind of the key messages related to exercise that you teach in these courses, but then also cover kind of some of the characteristics of how we should implement strategies in terms of whether, you utilize media, but then, what other characteristics should there be when we're trying to educate people and implement some of these exercises. But first, what are some of the key messages, foundational principles related to exercise that you teach in Too Fit to Fracture?
So I'm gonna talk both about exercise and physical activity because they are different. So with exercise, we sort of highlighted kind of 2 main recommendations. So one is that we recommend that people with osteoporosis engage in a multi-component exercise program that includes strength and balance training. Okay. And the second is that we recommend against participating in aerobic exercise to the exclusion of strength and balance training. And the reason for those 2 distinctions is that when I talk to many healthcare providers, there was a strong emphasis on aerobic physical activity and weight-bearing exercise. Mm-hmm. And the strength and balance training often got lost. Mm-hmm. And when you talk to people who have osteoporosis, they'll talk about how they walk as their primary form of exercise. So the message that multi-component exercise is important is not being translated. So we wanted to make sure that we worded the recommendations such that we made it very clear that strength and balance training was important, because the evidence suggests that balance training can reduce falls, that strength training may prevent muscle loss and perhaps even bone loss. So we wanted to make sure that was there.
Yeah, sorry, I'm going to interrupt real quick. So when you recommend strength training, what does that look like? Because I know for one person that may be, seated TheraX with some TheraBand, and for another person it may be deadlifting a barbell off the ground. But I know each person is going to dictate what you do. But when you hear strength training, what comes to mind?
Well, so the recommendations actually just specify that you're doing work against resistance at an intensity of 8 to 12 RM. However, if you're really thinking about strength training is usually a much lower rep range. So usually you have, 6 RM or less, especially if you're thinking about, really building strength. But we focused on 8 to 12 RM because it's consistent with the ACSM guidelines for older adults. And also it's a nice balance between strength and hypertrophy. And we do know that people lose muscle with age. So we want to build both strength and muscle size. So we don't advocate specific types of exercise. We just say that you want to engage your major muscle groups in a strength training program, and you want to work in an intensity of 8 to 12 RM. It's not to say that we recommend against higher intensity. And that's an important distinction, because there was actually a paper published in Osteoporosis International that said, that the guidelines recommend against it. And that's because we said, well, if, you do 8 to 12, and if you can do less than 8, it's too hard, and more than 12 is too easy. And that was just me defining what 8 to 12 RM means, because most of the readers wouldn't know, right? Not because I was saying that people with osteoporosis shouldn't do less than 8. Right. We're not recommending against higher intensities. It's just that if you take a person who's not, we're making these recommendations for a wide variety of people.
Yeah, and that's
there's many people for whom I would not recommend a 6 RM rep range. Although I might want to increase strength in that person, it just may not be the right decision for that person, because perhaps they've never done strength training before, and you're not going to throw a 6 RM weight training program at someone who's never done strength training before. So it's a nice balance between sort of still achieving strength and hypertrophy, but also making it a bit more realistic for people who've never exercised or people who are at high risk.
Yeah, that's a good point.
Yeah. So I don't know if I've answered your question. But,
no, you did. And I think because a common topic on this podcast is the theme of rehab professionals not challenging older adults and just really challenging the status quo with the 3 sets of 10 of seated TheraX exercises, and just seeing how for many people, not all, but many people, it's not as effective as what we potentially could be. So yeah, I was just asking from that standpoint of what do you perceive as strength training?
Yeah, so I think you need it to be a challenge. So certainly you might at first focus on alignment before you focus on intensity. But I think you want to choose exercises that are going to challenge people. And I'm not a fan of seated exercise. I'm not a fan of TheraBands, to be honest. We do use TheraBands in the Bone Fit workshop, and that's because it's hard to do thoracic extension where it's hard to do thoracic extension with weights without having people do sort of prone exercise and weights on their back. And I'm not, that's a challenge to do. Right. So we use TheraBands, but we use them primarily for our thoracic extension exercises when we want to add resistance. But, and also we use TheraBands because people find it easy to use those in their home. But to be honest, if I'm designing an exercise program for someone and I have access to a wide variety of tools, or they're willing to purchase whatever they want for their home gym, the only thing I would use TheraBands for is thoracic extension. And even then, you can probably do it without them. You can probably do other things. I would focus on using free weights because I like the idea of, the fact that you have to balance and you have to use accessory muscles to try to stabilize yourself. And I much prefer them to machines, and I much prefer them to any other strategy. Or even you can design really good body weight exercises that are much more functional. So, and I would, the only people I would do seated exercise in are people who can't stand. And people who, if you're teaching a group exercise class and safety is an issue,
Yeah.
So if you have a bunch of people who have balance and stability problems, and you are in a financially restricted environment where you have to teach a class to 10 people, and you only have one of you, you may be limited to seated exercise only for safety reasons. Yeah. But even then, I would try to get each one of those people up out of their chair and work with them individually as the other people are doing other things. I mean, we're in a society where we've engineered physical activity out of our lives, and we're pretty much always seated for our work and for our leisure. And so you want to get people out of their chairs, because you envision older adults, what you see often is the humped spine, where they've got weak back extensors, they've got tight pecs, they've got tight hip flexors and tight calves, and we need to move people around to ensure they maintain range of motion. And so I would not advocate seated exercise. And I would strongly encourage people to choose body weight exercises, choose exercises with free weights that challenge people, but also focusing on alignment and thinking about the person's risk. So if someone, for example, has osteoporosis and they've had spine fractures, I'm not going to get them doing overhead shoulder presses with weight. I'm not going to be, loading their spines down with a barbell, if they're at high risk, at least not without progressing them up to that stage at first. So that's my opinion.
Yeah. Yeah.
I'm all pro challenging people.
It is a fine line, and that's where I think it comes down to the skill of the clinician, because each person is going to be different, and we can't make blanket statements by any means, but we do need to challenge people to do it in a safe manner, for sure. What are some of the key messages in terms of physical activity?
So I didn't actually finish the key message around exercise.
Oh,
so we did
break
it. We did break it down in that we do want people to do 8 to 12 RM. We want people to do balance training daily, and we do want people to do aerobic physical activity at a moderate and vigorous intensity for at least 150 minutes a week. And the only caveat there is that for people who have a spine fracture, we probably focus on moderate intensity physical activity, aerobic physical activity, and we would also probably focus more on alignment than intensity, at least at first. So those are a few things. And the other thing we would add is exercises for posture. And so exercises that target the back extensors. And a lot of people, when they think about osteoporosis and targeting, posture, they think about shoulder retraction. And I want to emphasize that it's actually the back extensor muscles that we want to target, because that's what often becomes weak, and that's what we can do, target. And it's not to say you can't target your shoulder retractors, but we do want to make sure we also target the back extensor muscles. And for physical activity, the recommendations focus on how do we move safely. So we think about what people are usually told when they have osteoporosis, and it's like, don't bend, don't twist, don't lift more than 5 pounds or more than 10 pounds. And we want to make sure that we're making recommendations that aren't a disincentive to physical activity. Yeah. So the don'ts create fear, right? So don't do this, don't move, essentially, right? It's very difficult to get through your day without bending and twisting. Yeah. So that people don't understand the nuances and what people are really saying. And I think what we sort of emphasize is you want to try to modify or avoid rapid, repetitive, weighted, or end range bending or twisting. And so that changes it, right? So it's not to say that you can't bend or twist, but when you bend to put on your shoes, maybe, sit in a chair and put your foot up so you're not bending to end range, and you can focus on using a hip hinge strategy as opposed to a, spine flexion strategy. Mm-hmm. Or if you're, putting your groceries in the fridge, you need to twist and you need to open the door and, move around. It's not to say that you can't twist a little bit, but maybe think about not twisting to end range. So not twisting all the way around to grab something out of the shelf or the back of the car. Or, if you're holding a heavy object, that's when bending or twisting becomes even more problematic, because you've loaded your spine with that heavy object, right? You're holding this heavy object, you have to support that. And then if you bend and twist, you're then adding additional forces onto your spine. So we want to make sure that, you think about when you're moving around with a heavy object, that's when you really want to be careful about, end range flexion, or so you think about the person getting something out of the trunk, right? Yeah. If you're getting something really heavy out of the trunk and you're also bending forward, that places a lot of compressive load on the spine. So it's the rapid, repetitive, weighted, and end range flexion and twisting that we want to educate people about, not just don't bend or twist at all. Because I actually had someone ask me after a talk, my doctor told me not to bend or twist. So does that mean I have to walk around like a robot?
Well, that's what you see most of the time, or I see it as a home health PT.
Yeah. So it's
afraid.
not, so we don't want to create that fear. And really, if you think about it, if you don't move around, then you lose range of motion.
Right.
So you do need people to move. So, it's not to say, if you want to bend or twist, it's how you bend or twist and what are you doing in that moment and what are you holding in your hands and how quickly are you doing it? Because those are the things. When you hear the stories about people fracturing, it's often they're moving quickly, right? I had to bend quickly to do this, or they're bending to end range. So I bent to put on my shoes and they're bending all the way over, right? Yeah. They're twisting really quickly. Those are the types of things that often cause a fracture. And so those are the types of movements. But it's about how do you modify it as opposed to don't ever do it.
Yeah. I like that advice because I work with people kind of on the back end of a spinal fracture. And whether it was recent or, 5-10 years prior and to see the lasting effects of the fear of the don't bend and how limiting that is for people. I mean, it's a real thing, especially weightlifting restrictions, like the 5-pound, which, I mean, is that even researched? I don't know. That seems kind of just
there's no evidence
number
to support it.
Yeah.
And the reality is people don't often fracture when they're like people who have fractures know not to lift heavy furniture, right? Yeah. They're not, that's pretty easy to figure out. The issue is when, it's like, oh, can I lift my grandchild or can I lift my groceries? And it's simple things like, okay, well, if you have to lift groceries, put one bag in each hand.
Yeah.
Because then you're dividing the load and you're balanced. So you don't have as many muscle forces pulling on your spine and you don't have that twisting torque, right? Whereas if you have one grocery bag in one hand, you have muscle forces that are having to pull to counterbalance that. And then you're often, as you move around, creating, more of a twisting torque because you're unbalanced, right? So it's thinking about how you move. And the other thing that I want to mention is the idea of pain relief in people who have fractures. So many people who have spine fractures have chronic pain. And it's how can we actually teach them not only to move safely, but to do things to reduce that pain. So one of the things we actually advocate for people who have spine fractures, who want to work on, spinal extension, is lying in the supine position on the floor on a hard surface.
Yeah.
Because if you think about it, it promotes, whenever you lie down on a flat and without a pillow under your head, if you lie in that position, you're actually promoting extension of the spine and you're, kind of stretching out the front shoulder muscles. And that's when you can work on things like, okay, make your shoulders feel heavy into the floor, or imagine your collarbones or wings and you need to spread those wings. And that's when you can actually work on spinal extension in an unloaded position. Right? Yeah. You've just unloaded your spine by lying down. And we often teach our back extension exercises in that position because it's easier for people to focus then on those muscles, but also because it unloads the spine. And for some people, it can actually promote pain relief. So if you just tell them to lie in the supine position a couple of times a day to unload their spine, because all day they're walking around and their body weight is loading their spine. It may actually help. We don't know this. There's not a study that's done this and shown it, but it makes sense. And it's something that, when talking to physios, that they recommend. The only caveat is when someone has hyperkyphosis, right, they lie in the supine position. Their head doesn't usually touch the floor. Yeah. So that's when you want to optimize pillow placement. So you would want to use pillows. So you want enough pillows that the person's, head isn't just hanging there, but not so many that you're actually propping them up.
Yeah. Do you recommend many prone activities?
In the Bone Fit class, we do teach prone activities. I think the issue with prone activities is people need to know how to do them safely, and they need to know how to transition in and out of them safely. Yeah. So that's where injuries can happen. So if someone is being instructed by a physical therapist who knows how to teach transitions and to teach safe performance of prone activities, I think it's fine. And in some cases, it can help. But I think you can also get away with doing other things to try to target those muscles without doing prone activities. And there was one study where they looked at exercise interventions in people who have a spine fracture, and they found, and two people actually fractured. One was rolling from supine to prone, and the other was doing prone exercise. So that concerns me a little bit. But again, I think if you have instruction on safe transitions and safe performance of the exercise, it's not as much of an issue.
Yeah.
I'm just going to close my door. People are now arriving.
That's all good. So you mentioned before of tackling the topic of if bone can become more resilient when someone has an osteoporosis diagnosis and they're on those medications that slow down the healing rate. So that can be an issue. But I'm wondering, in your mind, are there cases where one would want to load the spine, say, progressively loading flexion in a very safe, slow manner to try and promote some bone resilience, some growth?
That's a really good question. I don't necessarily think you need to promote flexion to do that, because if you think about it, your body weight acting on your spine is applying a load to it. Yeah. And every time you activate muscles that are attached to the spine, you're applying a load to it. So I don't necessarily think you need to promote flexion to do that.
Okay.
It'd be hard. It's hard for me to answer that question because I don't have a study that says, oh, if you do flexion exercises, you're going to increase bone mineral density. Yeah. But I think that I would rather teach people to do, exercise that has impact, like walking or dancing, and then also exercises that involve muscle strengthening, whereby you have to stabilize during those exercises, and then you have muscles pulling on the spine, or doing back extensor exercises and core isometric abdominal exercises that will also have muscle forces pulling on the spine. Yeah. That would be my preference, because those are also much more useful in, we sit in flex positions all day. I don't think we need to train our muscles to flex. I think what we need to do is train our muscles to stabilize our spine so that we can reduce the risk of injury. And so I would rather teach. So for the core, we focus on muscle endurance. So we don't focus on strength. We focus on muscle endurance because we need our muscles to be able to stabilize us, for long periods of time. And those muscles are designed for endurance. So I would prefer to teach people to stabilize their spine, have good alignment. And in that, you're going to have muscle forces pulling on the spine. And then during their resistance training exercises, to stabilize, and you add extra weight so that you're challenging all of the bones where muscles are pulling on the spine, and then adding, some sort of aerobic physical activity that includes some impact if possible. Yeah. That would be my preference than choosing flexion exercises. That said, I do think it's important to maintain range of motion. So, having someone get on their hands and knees and do sort of the cat-camel type thing, but maybe not to end range, helps to promote range of motion, right? So that would be okay.
Yeah, and I agree with you. I'd add. I'm just thinking in my limited experience. I've only been out of school for 4 or 5 years now, and the people that I have done flexion with, I haven't necessarily loaded a ton of spinal flexion in that specific movement, but it has been beneficial for the people that were told to never bend forward 5-10 years ago, to where it helped them, kind of like you said, that they make sure that they maintain that range of motion. I train that to make sure that they have that range of motion in a fearless way, in a way that they aren't going to have some of those issues related to that movement, those fear-based issues. But
it's also thinking about teaching them the safe strategies. So can you get a dowel out and teach them how to do a hip hinge? Yeah. Right? Yeah. And teach them how to bend with their hips, knees, and ankles, as opposed to forward flexion with the spine only. And that can be really empowering, right? Because you can teach people how to bend safely.
Yeah. Yeah, we've had some good discussions. There's a Senior Rehab Project Facebook group, and they're on the previous podcast, Margaret Martin from Melio Guide. She's a Canadian physio, and we talked about flexion and deadlifting, and that brought up a really good discussion about there may be certain instances where where flexion is okay, and this was not necessarily from someone that already has an osteoporotic diagnosis, but to where some people load flexion to try and build resilience, and then a lot of people brought up the kind of the old strongmen, which I mean it's a completely different population, but just some of the people that loaded a flexed spine deadlift with hundreds of pounds after they've been progressively working on it for years and years and years, but just how some people can kind of break the trend, I guess, of only loading the spine in that straight fashion while doing a hip hinge. So I mean, the cat's out of the bag. It seems a lot of people have differing opinions and have differing successes with people. But it's an interesting topic that I don't have a good answer to per se, but I definitely lean towards the side of caution and follow a lot of what you talk about.
I think, I'm not saying it can't be done. I guess I just wouldn't want to be the physio that creates a fracture or a disc herniation, right? So, I mean, we know that, when you flex your spine and then you add load, you're going to increase your risk of those injuries. Mm-hmm. So, and the reality is most people are not doing these exercises under constant supervision.
Yeah.
So the messages that I'm promoting are with that in mind. The idea that I'm putting out recommendations that I'm not there to supervise someone.
Yeah.
I'm not there. I don't know if anyone's supervising them, or it might be their exercise instructor that learns my recommendations and implements them. And that person doesn't have a knowledge of anatomy or doesn't have a knowledge of exercise physiology. And so they're just like, oh, okay, it's okay to flex, right? So you have to be very careful in the language that we use because I'm sharing my language with everyone.
Yeah.
And so I have to make sure that the people receiving the messages that I give know how to implement them. So if a physio with years of experience who happens to also be a power lifter can teach someone how to progress to that point and they can do it safely, then that's their prerogative. But they're also responsible if that person injures themselves.
Right. And they're working with that person on a one-to-one basis as well, typically.
Yeah. So if it's anyone's prerogative to interpret what they should interpret science and theory as they wish to and apply it. But it's also their responsibility. They have to take responsibility for the consequences. Yeah. So I just, put out there that in my recommendations, whom I have to apply to those at moderate and high risk of fracture, and I have to know that physicians and physios and exercise instructors and kins and all sorts of people are going to take them. I have to make sure that that they're not misconstrued and that they do more good than harm.
Yes.
So that's where I sit. And so I would rather train, how do we move around with a stable spine?
Yeah.
I'm not saying people can't flex. I'm just saying, understand, how to move safely and when flexion can increase risk. But I couldn't in a recommendations document that's based on science and based on expert opinion say, well, in some instances it might be okay, because then an exercise instructor might hear me say that and say, okay, everyone's doing, crunches now because we need to train that time. Right.
Yeah. You're in a unique, I shouldn't say unique position per se, but I mean, you're producing this material for the masses. So you cannot assume anything in terms of how people will handle that information. That makes me.
But so are you, right?
True,
because those same exercise instructors may be listening to that debate. And so it may be very easy for physios who are listening to it, who are going to do one-on-one, to say, well, I can do this with confidence. But understanding when it's appropriate and when it isn't, it's a bit of a slippery argument.
Yeah, I know in my population, I haven't worked with anyone where I would be okay with them loading flexion without me being there. For sure. But so that kind of, I think it's a good segue into just kind of the characteristics of kind of usable material. So, I mean, you have your end user in mind, which is a lot of people. You're putting out this information for the public to consume and to use. So that's a consideration. What are some other considerations or characteristics that would be helpful for people like me, just a regular clinician, whether they're home health or work in the hospital or outpatient clinic, of what we can use to help make sure that people implement what we recommend in terms of exercises or whatnot once, they leave our care?
I think the biggest thing is thinking about behavior change theory and how you can actually help people make it a habit. Because if you give them, a lot of people have said, well, can't you just create an exercise program and put it online that people can follow? And I said, no, I can't. For one, the exercise program that I would deliver to a, 48-year-old woman who's had early menopause and has bone loss and was diagnosed with osteoporosis, would be very different than the 70-year-old prostate cancer survivor who has osteoporosis and wants to golf, right, or the 95-year-old woman who has 3 spine fractures and gait and balance difficulties. They're all going to be very different programs. So the sort of, here's what I would recommend for people to use is difficult. And the second thing is that each one of those people has different goals and different lifestyles and preferences. And so the big thing is, how do you work with that person to figure out how they can choose a way to make exercise a habit? So it might be talking to them about, what's the trigger for this activity? So we want to work on balance. Here's some exercises we can do for balance, and allowing them to pick the ones that they like. And then what's going to be the trigger? When are you going to do this every day? How are you going to fit it into your lifestyle? And then creating a plan, and then finding triggers that help them make it a habit. Those are the things that I think are really missing. We often think about what exercises to tell people to do and what recommendations, and that's really important. But it's also really important to help people make it a habit. And it's particularly true for things like posture exercises or posture training, because awareness of posture is something you have to do every day, right? You have to do it during your daily activities. It's not an exercise you can do 30 minutes a day. So how do you teach people to become aware and make it a habit?
Do you have any good resources for people that want to learn more about change in terms of popular books or blog posts or articles that really spoke to you?
Yeah, so one is The Power of Habit by Charles Duhigg.
Okay.
That's a great book, and it talks a lot about creating cues and also creating rewards. So someone has to have a cue to do an activity, and then someone also has to experience a reward, and that's a good way to make it a habit. And he also talks about beliefs, being able to reinforce the belief that someone can do it. So when you were talking about your clients who were fearful of flexing, and you took them through some exercises to make them realize, yeah, you can flex and you can do it safely, you have to do it this way. That was you working on their fear and working on their belief system. And that's really important. So even just having someone believe that they can do strength training and they can see benefits, that's an important part of creating habits. So that's one. The second is if someone wants to work on sort of their strategies and conversation with their clients. There's a book on motivational interviewing, and I'm trying to remember the full title. I think it's Motivational Interviewing in Healthcare or something like that. Okay. And that's really helpful because it helps you sort of understand how to have the conversation with the person to help them come up with the idea, and how to roll with resistance, and how to, use open-ended questions to try to have a conversation, as opposed to saying, I, the dictator, say you must do these exercises 3 times a week and you're going to do them Monday, Wednesday, Friday. Right? So it's about having that conversation so that people can find a way to make it a habit, put it into their life, and also kind of make it like it's their idea, so that they buy in, right? So those would be 2 I would suggest. I mean, there's lots, but those are the first two that come to mind. And
I'll link those in the show notes for people that are interested in those.
Yeah.
So that's awesome. Well, let's transition and kind of wrap things up. I just want to ask you a few quick questions.
Sure.
And your answers don't have to be quick by any means. But what would you tell your 25-year-old self, knowing what you know now?
Wow.
Mm-hmm. We can keep it to career area of your life.
I think I would look. So often I didn't realize the potential opportunities that were out there. So I often did, what people recommended for me without actually exploring on my own what actually was out there. And I didn't realize how much was out there and all the different things I could potentially do. And so I wish I had I read different books and I talked to different people and maybe tried different training opportunities, I guess. So I didn't explore enough, I guess.
Yeah.
I guess that's the big thing. But I think that's something that it's hard to know. Like, it's something you develop that curiosity over time, and what you're curious about changes over time. And so the things I'm curious about now, I wasn't curious about then. So even if I could tell myself, I don't know if my 25-year-old self would listen, to be honest.
Right. Yeah. It was more about the process that formed you, it seems. What pieces of technology, apps, or even, equipment, exercise equipment have been helpful for you in your work? And let's focus more on working with people, with patients.
That's a difficult question to answer because I don't really see clients anymore. I think that, a lot of people find help with tools that help make things a habit, or tools that help with self-monitoring. So, there's a lot of people who are into Fitbit and Garmin and all those things. And I do think there's a place for those things. I don't think they work for everyone, but anything that will help you with self-monitoring. Because as soon as you have to write something down or keep track of something, the more likely you are to make changes. So I do think that, but it doesn't have to be a Fitbit. It could be a journal. It could be an online app that has you track things. It could be, there's lots of different things you could use. So I think that that's important. Anything that helps you plan. And for some people, that might be cognitive behavioral therapy. And for other people, it might be just writing down a plan. And for some people, it might be having a friend that helps them stick to their plan because they go together every single week. So whatever it is, you need something to help you plan so that you're making it a habit, and then something that helps you monitor what you're doing over time to make sure that you're achieving those goals.
Yeah, I could use that for sure.
We all could. Right?
Yeah. Other than BoneFit, what has been the most transformative continuing education you've consumed?
I would say that having good mentors is the best form of continuing education. And I use mentors in a plural sense. I think that I've often had multiple mentors at any given time. And it's being able to call upon those individuals and ask them questions and learn from them. And they're not always people who are older and wiser. Sometimes they're my students. But the idea is that having people in your life that challenge you, I think is the best form of continuing education. I think the reason why people have career changes or they're unsatisfied with their career is because they're no longer challenged.
Yeah. You can name drop if you want to some of those people.
Alexandra Papuanu, Lahana Tabani, Neil McCartney, Milos Popovich, Kathy Craven. There's lots.
Awesome.
Yeah, I've worked with many wonderful people, and it's been a great experience. And I'm often always looking for I like learning trial by fire. So if I don't know how to do something, I'll often design a project so I can do a study so I can learn how to do it. So for example, one of the things on my bucket list was learning how to do a meta-analysis. I signed up to do a Cochrane review because, that's the gold standard, right? So why not figure out how to do it?
Man, you throw yourself out there. I like it.
Well, but why not, right? You keep yourself challenged, and I think that's the best form. And so it doesn't have to be a particular course. It can be, but it could also just be finding a person you want to learn from.
Yeah, awesome. All right, so last question. Let's say we are at... Are you familiar with CSM? What would be the Canadian equivalent of CSM? I'm trying to think here.
What's CSM?
CSM is the American Physical Therapy Association's combined sections meeting. It's
our
biggest.
Just the acronym threw me off. Yeah, okay. I know what that is.
What's the Canadian equivalent of that?
Will probably be the Canadian Physiotherapy Association annual meeting.
Okay. Well, let's say you were there and you have every geriatric rehab clinician in the room and you have their attention for, 30 to 60 seconds or so. What would you want them to know?
I think I would actually use that opportunity to ask them questions.
What questions?
I would want to know what they want me to know. I would want to know what the barriers are. I would want to know what their research questions are, what things that we need, what things we need to tackle so that we have good evidence to help people.
You're such a good researcher. I love it.
No, I mean, really, they can read papers and figure out those things. So like I can tell them, they know. I don't think it's my position to tell them what I think they should know, because what they need to know depends on their practice. So, I'd certainly be happy to answer questions, but they should be driving the questions. I shouldn't be driving the answers.
Right. I love that. That's awesome. Well, Lora Giangregorio, I appreciate your time and just sharing, your work, your interests, and just kind of your story of how you got to the point where you are now. It's pretty awesome to see, you take this kind of career in research and you are going out to the masses and educating people and doing it in a very thoughtful, informed manner. So thank you for doing that. And if people want to learn more about you and Too Fit to Fracture, Bone Fit and whatnot, where can people find you in those courses on the internet?
I'm going to answer that, but before I say that, I want to make sure it's clear that it's not just me going out and educating the masses and me doing all of this. It's a large team of people. So, for example, Judy Laprade has pioneered and led the development of Bone Fit. So it wasn't me. I worked with her and, we worked together. So she would be another person. We kind of co-mentor each other. Right. So we work together and I work with a lot of other people, at Osteoporosis Canada to do those things. So Ravi Jain at Osteoporosis Canada, helps to lead a lot of these initiatives and make them happen. So I just want to make that clear that it's not me doing all of this. It's a large group of people. So that's one thing. And the second thing would be, so Osteoporosis Canada has a website and they have a lot of different sections. So they have a section for healthcare professionals. So there's a lot of resources there for people who want to learn about osteoporosis. And then we actually have a Too Fit to Fracture landing page on the Osteoporosis Canada website. So if you Google Too Fit to Fracture, you'll find links to a lot of the resources that we've created. Okay. So for example, we have a 21-part video series that you can use with your clients. And the video series features cases and how those cases became active and what their exercise programs are. We have a one-page summary that people can hand out to their clients that feature the recommendations, but also have links to those resources so that their clients can go find them. And the one-page summary is really helpful, actually, just as a quick handout sort of thing. And we have a booklet, and we're actually revising the booklet. So the booklet's available for download on the website, and then we're going to put out a new one in a couple months, and it's going to be awesome. So highly recommend. And then bonefit.ca is where you can learn about the workshops. And if people want to host a workshop, they're usually willing to make it happen. So if you, for example, want to host one in your community, you just make sure you have enough people to be able to support it, and you contact Osteoporosis Canada, and they can often try to facilitate it for you.
Okay. What if they are American physios?
That's fine. We've had them in the States. We had one actually at the Combined Sections meeting last year, I think.
Nice.
And I believe they're doing another. Trying to remember. I heard that they might be doing another one in the States. Like I said, they're happy to do it. It's just about making sure that we can have enough people in it to make it worth the trip. Because we don't make money. They don't. I don't say we. Osteoporosis Canada doesn't make money off of workshops. They just cover their costs. So it's making sure you have enough enrollment to cover the costs, and the travel costs are a bit higher when you're going out of country. So
yeah. What about Twitter?
So I have a Twitter handle. I'm trying to remember what it is. I think it's at @L_Giangregorio, which in itself is complicated to find because you have to be able to spell my last name.
It'll be in the show notes. I'll put it in there.
And Osteoporosis Canada also has one.
Okay.
So.
All right. So those are all the places. So people, if you have research questions or want to pick Laura's brain, hit her up on Twitter, and I'll have all the links to the courses and all this awesome information in the show notes. So once again, I appreciate your time, and just thank you for your work.
Oh, it was a pleasure. Thanks for having me.
Hit me. I appreciate you listening to the Senior Rehab Podcast. The show notes can be found at seniorrehabproject.com, as well as some other helpful services and products that are offered at a discounted rate to you, the amazing people that listen to the Senior Rehab Podcast. So, until next time, my friends, please do not forget to stay funky.